A very good afternoon to one and all present here. I am Dr. Bhavani. And my topic for today is optic neuritis masquerading branch retinal vein occlusion. Optic neuritis, it is an acute inflammation of the optic nerve. It is a demyelinating condition that usually causes painful monocular vision loss. Classified into three types: papillitis, neuroretinitis, retrobulbar neuritis. There are two presentations: typical presentation and atypical presentation. In my case, it is to report a case of an atypical presentation of optic neuritis. There was a 21-year-old female presented with the chief complaints of right eye diminution of vision since 5 days with no significant past medical or surgical history. There was no history of systemic comorbidities. She was not on any medication toxic to optic nerve, and there was no relevant family history. Best corrected vision: the right eye CF2 meters improved to 612, left eye 660 improved to 66 with normal color vision. The anterior segment evaluation showed grade 2 RAPD in a right eye. On fundus examination, there were multiple hemorrhages along the superior temporal vein with hyperemic disc and blurred disc margin in the right eye, with other eye fundus being normal. On subjecting her to FFA, there was areas of blocked fluorescence with overlying retinal vessels. This patient was referred to our retina department directly because she was diagnosed as a superior temporal branch retinal vein occlusion from other hospitals. She was advised for intravitreal Avastin. On thorough medical evaluation, there were multiple hemorrhages on fundus fluorescence on the fundus examination with blurred eye, with hyperemic disc and disc edema in the right eye, and the left eye was normal. On subjecting her to FFA, there were areas of blocked fluorescence and with overlying retinal vessels. Other eye FFA was normal. So we did the complete systemic evaluation and a systemic CBP, ESR, CRP, Mantle text, blood sugars, intraocular pressures, everything were normal. B scan was done, which was also normal. So the visual fields and OCT were also normal. So we came to diagnosis that it was an acute presentation of the optic neuritis. So there was a retinal hemorrhages which have been rarely described in the case of optic neuritis. In a case, patient have retinal hemorrhages majorly along the superior temporal vein, which was misinterpreted as BRVO. Nevertheless, acute presentation with RAPD was a clue of diagnosis for optic neuritis. So we went ahead treating her with the 3 doses of intravenous methylprednisolone, 1000 mg per day, followed by oral steroids of tapering dose. This was the fundus picture of this patient 1 week after the treatment, with a decreased hemorrhage and the visual acuity improving to 6.6. There was significant improvement in the visual acuity. In conclusion, the resolution of hemorrhages after the administration of steroids supports the idea that they were formed due to edema, compression, or venous congestion. We should keep in mind that the optic neuritis have a variable presentation. RAPD and blurred disc margin is an important clue in the diagnosis of these cases. Retinal hemorrhages can be present even in the near normal disc. It is important such cases of atypical optic neuritis are recognized early and initiate proper treatment with corticosteroids. There is a higher incidence of recurrence in these patients following cessations of the treatment. Therefore, patients are advised for regular follow-up. These are some of my references. Thank you.
Thank you. And with this, we come to the
Dr.
conclusion.
Sir, I have a question. Dr. Bhavani, I have a little doubt that your patient was having RAPD, but your patient was having a normal color vision.
Yes, sir.
I think that is highly uncommon with the patient who is having optic neuritis, because in optic neuritis, that color vision and contrast sensitivity reduces very fast even if the vision is fading. So I think that this RAPD is because of that BRVO element, that RAPD grade 1 or 2 was there. So it can be because of BRVO, and your patient responded to BRVO to steroids, because inflammatory causes are also there which are responsible for this BRVO, inflammatory BRVO.
Younger patient.
Yeah, so if you are having a younger patient like that, Shivangi Kapoor, Dr. Shivangi has presented one patient, 14-year-old boy, who was having a cilioretinal arterial occlusion. So if you are seeing vascular occlusion in a younger patient, I think it is advisable to rule out the other non-common causes of vascular occlusion, particularly the inflammatory one and the collagen tissue disorders.
The MRI and everything, they was normal, sir.
So in MR,
That was also done. That was also normal.
I think one test which could have clinched the diagnosis was VEP. If it is optic neuritis, VEP would definitely be prolonged.
yeah. And your patient was having a normal color vision.
Normal color.
Whenever you are, I have a patient who was treated elsewhere as optic neuritis. Patient came back after 2 months to us, And when we evaluated, we found that RAPD was absent, color vision perfectly normal, contrast sensitivity was perfect. So we thought that this cannot be a case of optic neuritis. We did an ultrasound because we are seeing some ILM folds and subretinal fluid. So when we did that, we found that incomplete T sign. We did an ultrasound, that FFA, we found that pinpoint leakage. So we suspected it's a case of posterior scleritis. We did a immunological workup, young patient. What we found that C-ANCA was positive. I took the help of my immunologist friend. We did a CNS, that PNS X-ray, because the patient was having the history of recurrent cold, and we found it was a case of vaginous granulomatosis. When we put our patient on IVMP followed by cyclophosphamide infusion, patient responded very nicely. So all that glitters is not gold. A famous quote from William Shakespeare, Merchant of Venice, that if it is inflamed disc, it's not always optic neuritis. It can be anything else. Thank you so much.